Can I start? One, two, 1, 2, 3, start. Now, let's talk first about cardiac action potential by the cell.
So, if you have to understand,
Cut. सर ये वाला लाइन मैं हटा देता हूँ by cardiac action potential मैं यहीं रहता हूँ तो cardiac action potential काट देना है.
this will also correspond cut 1, 2, 3.
Cut.
कितना हुआ? 1 घंटे के आसपास ही हुआ है.
कम हुआ है.
कम हुआ है ना.
बहुत अच्छा हुआ है सर. बहुत फ्लो में हो गया एक ही बार में, वरना बहुत टाइम लग जाता है.
होपफुली साउंड सब कुछ आ जाएगा. आई थिंक स्टूडेंट को अंडरस्टैंडिंग होगा.
बहुत अच्छा पढ़ाया सर.
ना सर.
1, 2, 3, start. So here we are again with an integrated session of cardiovascular system. Hello students, myself Dr. Ankit, your pharma faculty.
And myself, Dr. Soumen, your physiology faculty.
So let's start with our integrated session of cardiovascular system, and we will start with arrhythmia.
So now if you have to understand the mechanism of the anti-arrhythmic drug, first you have to understand how the action potentials is happening in the heart, what is the ionic basis of action potential. Now, as you can see here, two diagram I have made here already. The left-sided diagram, this is the diagram of action potential taken from myocardium, right? So myocardium means this is the action potential typically seen in case of atrium and ventricular muscles. But on the right-hand side, the diagram which is made here, this is the typical diagram of action potential taken from the nodal tissues of the heart, right? So nodal tissue means SA node as well as the AV node, right? Now this myocardium action potential is also known as the first type action potential. You will understand why. So this is also known as the first type action potential. And the nodal tissue action potential is known as the slow type action potential. Now this fast type or slow type action potential is based on the phases, that is the phase number 0 of the action potential. So what is that phase number 0? Look at this action potential. So this is the action potential x-axis. So this is the time axis, and this is the y-axis. This is the membrane voltage axis. So we all know that normally when the heart is not stimulated, what will happen? The membrane voltage will remain at minus 90 millivolts. So this part, this flat portion of the action potential, this is minus 90 millivolt, which is nothing but the resting membrane potential of the heart. Now the resting membrane potential phase is also known as the phase number 4 of the action potential. Got it? Now after this phase number 4, when the membrane voltage is suddenly rising upward in the direction of depolarization, and it can maximum move up to plus 35 millivolt. This phase is known as the phase number 0 of the action potential in myocardium tissue. Then we can find out here that there is a brief phase where the membrane voltage is returning towards the baseline. So this is a kind of repolarization, but this repolarization phase is not the complete repolarization. So that's why this is known as the phase number 1 or the transient repolarization phase of action potential. Then you can find out here that there is a flat portion of the action potential. This is known as the typical plateau phase of the action potential, which is also known as the phase number 2 of the action potential. And after phase number 2, the phase number 3 will be there, where the membrane voltage is completely returning to the baseline or the resting membrane potential, which is known as the typical repolarization of the action potential, which is also known as the phase number 3, right? So these are the different phases of the action potential in myocardium or the first type action potential. But if you look at the nodal tissue action potential, first of all, the membrane voltage start from minus 65 millivolt, right? And from this minus 65 millivolt, when the membrane voltage is rising upward slowly, this phase where I have put this yellow highlighter, this is known as the pre-potential phase of the nodal tissue action potential. So this is one of the very, very important part of the action potential, which is known as the pre-potential phase of action potential, or also known as the diastolic depolarization. This is like RMP of the myocardium action potential. That's why this is also known as the phase number 4 of action potential. Got it? Now when this phase number 4 is peaking upward, which is going upward, and then when it is reaching at a membrane voltage of minus 40 millivolt, this minus 40 millivolt is the threshold voltage of the nodal tissue. And you all know that whenever you cross the threshold voltage, what is going to happen? The actual action potential phase, the actual action potential will start. So this part where the membrane voltage is going upward, as you can find out here, so this is known as the phase number 0 or the depolarization phase of action potential. Now you compare the phase number 0 of the myocardium action potential and phase number 0 of the nodal tissue action potential. In case of myocardium, the phase number 0 is rapidly going upward because this is known as the first type action potential. And in case of nodal tissue, this phase number 0 is rising slowly upward, and that's why this is known as the slow type of action potential. Now where they are first rapidly rising upward and why they are rising slowly upward, you will understand if you look at the channels which is responsible for them. Okay, but before that, look at, in case of nodal tissue, after the phase number 0 is over, the membrane voltage will again return back to minus 65 millivolt, which is known as the repolarization phase of action potential, which is phase number 3. Now we will try to understand quickly what is the ionic basis of this different phase of action potential in both the cases, right? So the first is the action potential in the myocardium, or the first type action potential. So to understand the action potential ionic basis, I am drawing one cell here. Suppose this is the myocardium cell, right? So when the membrane voltage is in resting condition, we know that the membrane voltage inside will be negative and outside will be positive. That is the normal resting membrane potential. Now, whenever this membrane voltage will reach to a threshold, okay, what will happen? Almost all the voltage gated sodium channel which are present on the membrane surface of this myocardium cell, they are going to open up simultaneously, because of which huge amount of sodium is going to enter inside the cell. And because of the entry of sodium, what will happen? The inside voltage will be positive, that is the depolarization, and it will give rise to the phase number 0 of the action potential. So phase number 0 or depolarization phase is due to sodium entry, and this sodium enter through a channel which is known as the voltage gated sodium channel, which is very fast in nature. And then after the phase number 0 is over, if you look at the phase number 1, which I already told that this is a transient repolarization. Now the repolarization means what will happen in these phases? The potassium will go out, or there will be efflux of potassium from the cell. So whenever there is efflux of potassium, we all know that the cell is losing positive charge, right? So if the cell is losing positive charge, what will happen? The inside positivity will decrease. So that's why the membrane voltage is returning towards the repolarization or RMP. But here in phase number 1, the repolarization is not complete. We can suddenly see here that there is a stabilization of the membrane voltage. So why there is a stabilization? Although the potassium is going out, or the exit of potassium is going on, suddenly what will happen? There will be opening up of the voltage gated calcium channel, and because of which calcium will start entering inside the cell. So now, as you can find out here, the calcium is entering in the cell, and as well as the potassium is also going out of the cell, and both of them are positively charged ions. So what will happen? Both of these positive charge will balance out each other, and because of which the membrane voltage will stabilize, and this stabilization of the membrane voltage is known as the plateau phase. So the plateau phase, you have to remember, the potassium exit or efflux of potassium is also going on, as well as the calcium entry is also going on parallelly. Now, when the phase number 2 is ending here, what will happen between this calcium and potassium channel? Now the calcium channel will be closed up. So now the calcium channel is closed, but potassium channel is still open. So if the potassium channel is only open, but the calcium channel is closed, then cell is going to lose huge amount of positive voltage, and that will leads to the membrane voltage returning to the RMP or baseline, and this is phase number 3 or repolarization. So if I ask you what is the ionic basis of phase number 3, you will say the exit of potassium or efflux of potassium and the closure of the calcium channel. And phase number 2, as you can see already here, that phase number 2 is calcium and potassium, both of the channels are open and they are balancing out voltage to each other, right? Now if we look at the nodal tissue action potential, now you have to be careful here, because the channels are different in case of nodal tissue action potential than that of the myocardium. So to understand this ionic basis here, again I am drawing one nodal tissue cell. So suppose this is the SA node or maybe the AV nodal cell. So what happens during this pre-potential phase? I told you this phase where the membrane voltage is slowly rising from minus 65 millivolt to minus 40 millivolt. This is the pre-potential phase. What happens in pre-potential phase? You remember that first there will be entry of sodium into this nodal tissue cell. But look at here, this sodium which is entering here in the nodal tissue cell, it happens through a different channel which is known as the HCN channel. And I hope you know that the sodium which is entering through this channel, this sodium current is known as the funny current, right? So this current is known as the funny current. So because of the funny current, what will happen? The membrane voltage will rise from this minus 65 towards upward direction towards minus 40. Then there will be opening up of the another set of channel which is a calcium channel. But this calcium channel is a T-type calcium channel or the transient variety of the calcium channel. But because of the entry of sodium and because of the entry of calcium, now the membrane voltage will reach up to the level of the threshold voltage. And whenever you cross threshold, I already told you what is going to happen. The action potential actually it will start, and that is the phase 0. But what is the reason for phase 0? Remember here, again this is calcium, but this calcium is a L-type voltage gated calcium channel. So for the pre-potential phase, first sodium is required, that is the HCN current, okay, that is the slow sodium, followed by you require calcium current, but that is transient calcium. But for the phase 0, the channel which is responsible here is the calcium channel, but that is L-type slow calcium channel. And after the action potential depolarization is over, then the repolarization is going to happen, and the cause of repolarization is similar to the myocardium repolarization. What is meaning that? Meaning this calcium channel which was open, that will be closed, and the potassium exit or the efflux of potassium will continue. That will leads to repolarization. Now, only one extra point you have to note here, that whenever we are discussing the nodal tissue, I told you that this HCN channel, what is the name? Hyperpolarization induced CAMP nucleotide gated channel. Now, this nodal tissue contain beta receptor, particularly the beta 1 receptor. If you stimulate this beta 1 receptor, the sympathetic stimulation beta 1 receptor, what will happen? The inside cell, there will be increase in the CAMP. Whenever cyclic AMP is very, very high inside the nodal tissue, in SA node or AV node, it is going to stimulate this HCN channel, as well as it is also going to stimulate the L-type calcium channel. So what will happen? This prepotential phase will be faster also, as well as this phase 0 will also be faster also, and because of which the heart rate will be increased, as well as the conduction velocity at the nodal tissue, that is the AV node, will also increase, right? So this is the basic difference between the ionic basis of different nodal tissue. Now the sir will tell what about the different anti-arrhythmic drug, what is the mechanism.
So now let's talk about the classification of anti-arrhythmic drug. So as we know, there are many ions which are causing depolarization and repolarization of the heart. That is sodium, potassium, calcium. We discussed about beta receptors. Let's block them. So there is a very famous classification, that is William Vaughan Singh classification of anti-arrhythmic drug. They classified anti-arrhythmic drug into 5 classes, class 1, 2, 3, 4 and 5. The first 4 classes, as we can see, the first 4 classes, they are, we can remember with the help of a mnemonic, SOBI-POCA. So for sodium channel blocker, B for beta blockers, PO for potassium channel blocker, and CA for calcium channel blocker. Now, apart from this, we have certain other drugs. Those drugs are miscellaneous drugs and they are kept under class 5. So class 5 will have miscellaneous drugs like atropine, digoxin, adenosine, and magnesium sulfate. Now, one thing you have to remember, that sodium channel blocker, that is class 1 agents, they are divided further into 3 classes, class 1A, 1B and 1C, on the basis what they will do to potassium channel. So class 1A, they will block potassium channel as well, apart from blocking sodium channel. 1B, they will open potassium channel, and most of the drugs in 1C will have no effect on potassium channel. Second point to be noted is, we know that all beta blockers are kept under class 2. So all beta blocker are kept under class 2 except one beta blocker, that is sotalol. Sotalol is the only beta blocker which is kept under class 3. So this is a very favorite question. Can you tell me the special property about sotalol? Yes, it's a potassium channel blocker. So before starting with each drug, let's understand, as the sir has already explained you, that in the muscles of atria and ventricle muscles or myocardium, this is the action potential. That is phase 0, 1, 2, 3 and 4. Now, if we give a drug which is a sodium channel blocker, it will affect which phase? It will affect phase 0. So we know that during phase 0, sodium enters, and which causes depolarization of myocardium. Let's block sodium channel. Can we say if we block sodium channel, the heart will depolarize slowly? So sodium channel blockers, they delay depolarization of heart, which we can write as they will decrease the speed of depolarization, that is dV by dt. So in simple word, it can be seen on this diagram as that sodium channel blocker, they reduce the slope. Slope means height of phase 0. Now similarly, we know that potassium channel is responsible for repolarization of the heart, and repolarization occurs because of outward movement of potassium in phase 1, 2 and 3. Now any drug that block potassium channel will delay repolarization. So can we say a drug which blocks sodium channel delay depolarization, And the drug that block potassium channel will delay repolarization. Can we say they will affect which phase? They will affect phase 1, 2 and 3. So let's make this diagram. If we block potassium channel, the heart will take more time to repolarize. If it will take more time to repolarize, this whole action potential duration will increase. Hence, any drug which block potassium channel increases action potential duration. That is due to phase 1, 2 and 3. So let's talk about the class 1 agent. We know that class 1 agents were sodium channel blockers. And we very well have understood as well that sodium channel blocker will reduce phase 0 slope. Phase 0 slope, which is also known as decrease in speed of depolarization, dV by dt, and on ECG, they will increase the duration of QRS complex. So let's classify these sodium channel blockers. They are further divided into 1A, 1B and 1C. 1A, 1B and 1C, all these drugs are sodium channel blockers. Because all these drugs are sodium channel blocker, let's see what they will affect. Action potential, how they will affect? They will reduce phase 0 slope. All will reduce phase 0 slope. But where they are different? They are different on their activity towards potassium channel. 1A, they block potassium channel. Hence, they will increase APD. 1B, they open potassium channel. So remember, 1B are not blocker, 1A are blocker. And because they open, they will lead to decrease in APD, action potential duration. And 1C, they have no effect on potassium channel. Hence, the action potential duration will remain same. So let's remember the names of these drugs. 1A, we can remember with the help of a mnemonic, Cupid. So Cupid for quinidine, prokinamide and diisopyramide. 1B agents, we can remember leave PMT, that is lignocaine, phenytoin, mexiletine and tokenide. And 1C agent, let's write famous Prime Minister or PM, flecainide, propafenone and morphine. Now another class of drugs, class 2 agents were beta blocker. Beta blockers on heart are indirectly inhibiting SA node and they are inhibiting AV node by blocking those HCN channels and blocking the entry of calcium into these tissue. Now, when SA node is firing excessively, we call it as sympathetic tachycardia. So which drug would you like to give for the treatment of sympathetic tachycardia, where SA node is firing more? Give beta blocker as a drug of choice. Second point, in SVT, supraventricular tachycardia, we have already discussed what we have to do. We have to prevent ventricular tachycardia. So in that case, we have to block AV node. So second use of beta blocker, by blocking AV node, they are the drug of choice for SVT to prevent ventricular tachycardia. So SA node blocking sympathetic tachycardia, and when they block AV node, they are given in SVT to prevent VT. So propranolol, it is now considered to be the drug of choice for sympathetic tachycardia. So sympathetic tachycardia can occur due to any reason when there is increase in sympathetic discharge like fever, hyperthyroidism, stress, anxiety, etc. Metoprolol and atenolol are very commonly given in SVT to prevent VT. And similarly, ismolol is an IV beta blocker, and in fact, it is the shortest acting beta blocker. Because of this reason, it is given during operation or intraoperative period to control sudden increase in the heart rate or to control intraoperative tachycardia. Now let's talk about class 3 agents. So class 3 agents are potassium channel blocker, and we have already discussed that potassium, it affects which phase of action potential? That is phase 1, 2 and 3. And if we block potassium, the heart will repolarize slowly and there will be increase in action potential duration. Now, don't you think if there is increase in action potential duration, one side effect of potassium channel blocker is that they increase QT interval on ECG. And these drugs, they themselves can increase the risk of torsades de pointes. Now, where we use potassium channel blocker. Remember, potassium channel blockers are mainly given for the treatment of re-entrant arrhythmias. Now, in re-entrant arrhythmia, what happens? There are two separate pathways in the heart, and we have to block one pathway. How we can block one pathway? If we block potassium channel, can we say the heart will remain depolarized? And if heart will remain depolarized, the heart will remain refractory to this re-entrant impulses. And re-entrant arrhythmia, remember, causes flutter and fibrillation. That is why potassium channel blockers, they are given for the treatment of flutter and fibrillation arrhythmia, which occurs due to re-entrant pathway. So let's see what are the different drugs we have in potassium channel blocker. We can remember with the help of a mnemonic DBAS. That is dofetilide, ibutalide, a new drug vernaculant, amiodarone, a very famous drug, and which beta blocker is under class 3? That was sotalol. And among them, try to remember one drug, amiodarone, a very famous drug. Amiodarone is now considered to be the drug of choice to control atrial rate and ventricular rate in AF and VF. So if you want to control the heart rate or heart rhythm in AF and VF, the most effective drug now we have is amiodarone. So indirectly, if I'll ask you a question, what is the drug of choice of ventricular fibrillation after MI? Your answer will be amiodarone, because it is the most effective drug. It has maximum mortality reduction ratios. Now, lastly, we have calcium channel blocker, a very unique drug. We know that in nodal tissues like SA node and AV node, phase 0 is because of calcium. And in myocardium like atria and ventricular muscles, this plateau phase or phase 2 is due to calcium. Now, calcium channel blockers, can we say they will block this calcium? Hence, they block SA node and AV node. And in atria and ventricle, they inhibit this plateau phase. Now we know that in myocardium, the muscles, they contract, they increase their force of contraction because of calcium. So just imagine if there is phase 2, during phase 2, there is ventricular contraction of myocardium. If you will give calcium channel blocker in cases of VF or VT, can we say calcium channel blocker, they decrease cardiac output because they inhibit ventricular contraction? Hence, calcium channel blockers are absolutely contraindicated in cases of ventricular tachycardia. But what about atrial tachycardia? Any drug that blocks AV node is given in the treatment of supraventricular tachycardia to prevent VT. So, calcium channel blockers are given in SVT because they block AV node, but they are contraindicated in VT because they suppress the contraction of ventricle, cardiac output will reduce, and the patient may die. So, which drugs we have among calcium channel blocker? Remember, these drugs, as the sir has explained you, they block L type of calcium channels. And L type of calcium channel is present in heart. So the drugs we have is verapamil and diltiazem. So verapamil and diltiazem, they are given in the treatment of SVT, but they are contraindicated in VT. Lastly, we have miscellaneous drugs. So in miscellaneous drugs, we have ADAM. Atropine, it is the only drug we have for the treatment of bradyarrhythmias. Digoxin also block AV node because it has a vagomimetic effect. That is why sometimes digoxin is given in the treatment of SVT, especially in heart failure patient, because digoxin can increase cardiac output. Adenosine, it opens potassium channel. Now, because it opens potassium channel, can we say the SA node and AV node, they will repolarize very fast. Hence, it reduces the conduction of SA node and AV node. So, indirectly, adenosine also reduce the activity of SA node and AV node. And shortly we will discuss about magnesium sulfate. So let's talk about the treatment of common arrhythmias. So the first arrhythmia we have to understand is PSVT, that is paroxysmal supraventricular tachycardia, or we can simply write SVT, supraventricular tachycardia. So in supraventricular tachycardia, what we have to do? The atria is beating more and all the impulses are coming to the ventricle. So that is why we have to prevent VT in cases of SVT by giving a drug which blocks AV node. So in the treatment of SVT and PSVT, we have to block AV node. How we can block AV node? The first thing, we can stimulate vagus nerve. So vagal stimulation, like Valsalva maneuver, carotid massage, eye massage, etc. But if the patient is having acute attack of PSVT or SVT, let's block AV node. And remember 3 drugs which are AV node blockers, that is A, B and C. So the first drug is adenosine. Adenosine is a very short-acting drug. It is considered to be the drug of choice for PSVT or acute attack of SVT because it opens potassium channel. Opening of potassium channel block the conduction of AV node. But for long-term maintenance of SVT and PSVT, we give beta blockers. Now, one additional point is both adenosine and beta blocker, they themselves can cause asthma. So if I'll ask you a question, SVT or PSVT in asthmatic patient, you cannot use adenosine or beta blocker. In that case, the safe drug is calcium channel blocker like verapamil. So verapamil is safe in asthmatic. So PSVT or SVT in asthma, we give verapamil. Now let's talk about monomorphic ventricular tachycardia, where you can see same QRS complexes. So why monomorphic ventricular tachycardia? Sir, the ventricle is beating more. And we know that ventricular myocardium is a fast conducting type of fibers. That means they contain sodium channel. So if you want to suppress ventricular rate in cases of ventricular tachycardia, the best drug you should give is block sodium channel. And now the drug of choice has become amiodarone. So one question will come into your mind, sir. Amiodarone we have discussed in class 3 agent, which is a potassium channel blocker. Yes, we keep amiodarone in potassium channel blocker, but amiodarone blocks all types of calcium. It blocks sodium, it blocks potassium as well. Because it is a sodium channel blocker, it is the best drug we have to control VT. But yes, you can use other sodium channel blockers as well, like lignocaine, procainamide, class 1 agent, flecainide, etc. for ventricular tachycardia. Now, last arrhythmia, you can see multiple types of QRS complex. Multiple types of QRS complex means polymorphic ventricular tachycardia, which is also known as torsades de pointes. In the treatment of torsades de pointes, remember, we never give amiodarone. Amiodarone itself can cause QT prolongation and torsades de pointes. Here the drug of choice is magnesium sulfate. The reason is very simple. Magnesium is a brother of calcium. Magnesium blocks calcium channel, which will inhibit this excessive ventricular contraction. Magnesium sulfate is the only drug we give for polymorphic ventricular tachycardia. So this is all from our side, sir. Anything you have to say?
Good. I think now we will be able to understand the basic mechanism of anti-arrhythmic drugs and the action potential of the cardiac muscles. So that's all from our side. Thank you so much.
Thank you, everyone.